and gentlemen. I'm very honored to be here to give my presentation. I'm very happy. This is my first time to this beautiful city. So I will share my experience of hereditary MTC diabetes treatment. This is the Chinese capital, Beijing City. This is our hospital. It is located in the center of Beijing. This is our parade this year. As we all know, that medullary carcinoma is divided into subtypes, sporadic and hereditary. According multiple analysis, multiple factor analysis, patient age and stage of disease at diagnosis is independent prognostic factor. So the early diagnosis is very important for the survival rate. Let's take a short break about the READ gene. READ gene is located in the chromosomes 10. Yeah, it has 21 exons and 3 different isoforms. So if mutation in point mutation for READ gene, the patient will suffer from MTC. Based on our knowledge, a many gene is related to the MTC, the cause of the MTC. Regarding sporadic MTC, READ gene KRAS and NRAS is responsible for the cause of the disease. Hereditary MTC have three subtypes, and it is responsible for different exons is responsible for different subtypes. But sometimes there is cross-cutting between different subtypes. This picture shows the rigid protein structure. This is transmembrane, and this green part represents extracellular domain, and this purple and red one represents intracellular domain, and different exons encode different parts protein, and different exon is responsible for different subtype. In our medicine center, we collect 18 pedigrees in total. Pedigrees, these hereditary MTC pedigrees. And it is genotypes and phenotypes were analysis. And at the same time, the in vitro experience was under study to investigate the function of the new point and compound mutation. This treatment roadmap, once MTC is diagnosed with final neutral aspiration, so first step is HPEO identification. We can use a ultrasound examination and blood test. If we get a positive PHEO case, we should perform PHEO surgery first. After that, we will continue 2 weeks later, we will continue MTC surgery. After that, we get the tumor specimen of the proband. We cut this one proband, and then we sequence all the READ exons. We get if we get a mutation, give the READ mutation in peripheral blood, that means the patient can suffer from a hereditary MTC. Once the hereditary MTC was diagnosed and the known mutation verified in his direct relatives from the peri-blood test after informed consent. If a positive blood mutation, we will continue CT and CA and ultrasound examination. We can identify the patient and the gene carriers from these results. If the patient suffered from distant metastasis, a clinical trial and chemotherapy will be considered. If the patient suffered if the patient without distant metastasis, MTC or PHU surgery will be performed. So for gene carriers, we will follow on each case will be follow up or receive prophylactic cerebrectomy according to different risk rank. If a career is at the age of the fertility, we will perform a pre-plantation genetic diagnosis because this is very important. We can control his baby and in guaranteed baby a young or a healthy one. So this whole this chart, from this chart we can see these altogether 18 pedigrees, including 11 kinds of the mutation. This point mutation is single point mutation. This is compound gene mutation. Altogether, there are 98 patients. In the largest pedigree, there are 28 patients. This chart shows the mean age at the diagnosis and of MTC or PHEO. So blue one stands for MTC. The red one stands for PHEO. So the youngest age of MTC is 50 years old, and for PHEO youngest is 19 years old. Interestingly, for these pedigrees, we can see there's no patient suffered from some PHEO for this pedigree. This chart shows the cases of this chart show all the patient and gene mutation and read mutation carriers altogether 1,011. 3 cases develop PHADP accounting for 2.7%, and PH32 cases develop PHEO accounting almost 13%, and 10 cases suffered from distant metastasis, and 8 cases diagnosed. 8 cases you died from distant metastasis and local advanced tumor. The discussion was because read gene for hereditary MTC, these patients have a germinal line mutation. So each cell of the body has the read gene mutation. So these patients suffer not only MTC but also PHEO, PHPT, CLA, HD, and so on. So cooperation with multiple disciplinary team is very important. Naturally, head and neck surgeon will be the leader or organizer of the whole MDT. Besides urology, endocrinology, anesthesiology, reproductive medicine center, genetic testing and consulting, diagnostic imaging center, and ICU, and so on. They will play a very important role in the whole in the procedure of the therapy. Discussion 2: the varying phenotype of the same mutation in different pedigrees. C634R mutation is very common in our data. So there are altogether 5 pedigrees. Pedigrees suffered from the same mutation, but their phenotype vary much. We can see this family 1. Altogether, these 6 patients, 2 carriers. 2 patients suffer from PHER, and 1 patient suffer from distal metastasis. For family 2, altogether 9%, 9 patients, but 3 patients die of distal metastasis. So mortality is very high for this family. In family 3, the patients almost 5 to 8, almost 80% patients have PHER. This is a very high ratio in PHER ratio in this family. For family 4, in family 4, we can see this patient almost more than 80 years old. He's still, but he didn't compare MTC. And this patient, many people died at very young. We don't know because it's a long time. We can't follow up. So what's the reason behind? So same point mutation, but the different phenotype. How to there are many answers. Many things. First one, how to evaluate the region SMP. Maybe SMP play important role in the phenotype outcomes. Is there any other unknown gene mutation participate the phenotype outcome and a different environment factor? Discussion 3. The features of the PHER. PHER is almost 70% can be as symptomatic. So mortality can be 50% because insufficient preparation for PHER. Occurrence, we can see this specimen. Almost every person will suffer from bilateral tumor. From this chart we can see bilateral tumor, bilateral tumor. Altogether, 10 cases suffered from distal metastasis. So invaded organ, the top 2 invaded organ is lung and the liver. Unfortunately, these 2 cases came from one family. The daughter and his father suffered from the liver metastasis. Discussion 5. Risk stratification. According ATS risk stratification, for that one is a high risk. For that 3, that 4, that 4 pedigrees, there is a moderate risk. But in our data, we still found 5 pedigrees suffered from compound mutation. There's there's still no guideline for this patient treatment. So now we pay more attention to for these patients. Discussion 5. Compound mutation. So different phenotype between compound mutation and single point mutation has been reported. Most of the data shows synergistic effect, and our data almost the same. For this, for that one, these reach 691. These are polymorphism. But if they combined or point mutation, it will be significantly associated with the increased risk of the MTC. This data. For this, you can see this for this diameter for this category. Yeah, for that one, the only single gene mutation. This is a single gene mutation, but for that one, this is a compound gene mutation. So this patient, very young, will suffer from MTC. These data show that this is a single mutation. There is no MTC. These combined MTC. This is a compound mutation. So patients suffer from MTC very young. At the same time, we carried out screened wound assay. These data reinforce our clinical findings. Discussion 6 operation according ATA guideline. Standard for treatment includes total thyroidectomy and dissection and cervical lymph node compartments. As for lateral neck dissection, we think we should. It is very important to evaluate risk factor. It includes CT and CTA level, and positive number of the central lymph nodes and the infiltration of the thyroid capsule and ultrasound abnormality in region 2 and region 3. Discussion 7, prophylactic and thyroidectomy. For this patient is very young, only 80 years old. Yes, according risk level, it is a moderate risk. So we perform a thyroidectomy. Altogether, two children received prophylactic thyroidectomy in our study. Discussion 8. How to treat HPTH is very according ATA guideline in 2015. There are altogether 3 methods to treat PH. HPTP, subtotal parathyroidectomy, total and resection on an enlarged gland. Our treatment is we choose a subtotal parathyroidectomy. We can see this parathyroidectomy is enlarged. If the patient suffers from distant metastasis, now we already perform clinical trial. We use the targeted therapy. That's a tyrosine kinase inhibitor, Anitini. We always perform short clinical trial, short stage. Discussion 9, following up. After thyroidectomy, all the patient need to closely following up. We should use the neck ultrasound or measurement of the CT and the CTA level. Individualized assessment is very important for this, according to different risk level. Discussion. So the last one is discussion 10. If a patient or career is in the age is at the age of the fertility, we should perform pre-implant genetic diagnosis. And in our hospital, this team is one part of the whole team. Conclusion. We think, based on our knowledge of phase, we think multidisciplinary discipline is very, very important for the hereditary MTC treatment. A single gene, we still, by far, we still think hereditary MTC is a single gene disease. But now we think maybe multi-genes participation is clinical outcomes. Further research should pay attention. Now we pay attention to compound gene mutation and retrieval and the construction of the variation of the rate protein and its corresponding function iteration. Thank you. Thank you for the attention.